Good morning, students. Today topic of our lecture is pelvic anomalies, pregnancy and birth in women with abnormal pelvis, pregnancy and birth in the case of large fetus, and functionally contracted pelvis. At this picture, you can see normal pelvis. Such as you remember, pelvis consists from 4 bones. It's two iliac bones, its sacrum and coccyx, and every iliac bone consists from ilium, ischium and pubic bone. I hope you remember it. The true pelvis is bounded above by the promontory and ala of the sacrum, the linea terminalis, and the upper margins of the pubic bones, and below by the pelvic outlet. The descending inferior rami of the pubic bones unit at an angle of 90 to 100 degrees to form a rounded arch under which the fetal head must pass. Again, at this picture you see what is false pelvis, what is true pelvis, and border between two types of pelvises. It's linea terminalis or its first plane, its plane inlet. For us, interesting some sizes. It's true conjugate, it's obstetrical conjugate and diagonal conjugate. And of course later I show what is it and explain how we can measure these types of conjugate. Such as you see, true conjugate, it's distance between promontorium to upper inner part of pubic symphysis. Obstetrical conjugate, it's from promontorium, from midpoint of symphysis, and diagonal conjugate from promontorium to the low margin of pubic symphysis. And such as you remember, in true pelvis, at true pelvis we have 4 planes. It's inlet, it's cavity, it's obstetrical outlet and anatomical outlet. 15% of those who give birth have an anatomically contracted pelvis. This applies to fine bonded women with relatively low height and fragile constitution. A small woman is likely to have a small pelvis, but she is also likely to have a small neonate. It should be kept in mind that a woman's pelvis is considered to be contracted if it does not match the size of the baby's head. Definition. Anatomical definition. It is a pelvis in which one or more of its diameters is reduced below average normal by 1 or more centimeters. Obstetrical definition. It is a pelvis in which one or more of these main diameters are reduced so that it interferes with the normal mechanism of labor and may be difficult spontaneous vaginal delivery. Factors influencing the size and shape of the pelvis. Developmental factor, its racial factor, nutritional factors, sexual and metabolic factors, and some traumas, diseases or tumors of the pelvic bones or abnormalities of lower extremities or spines. All of these factors may change size and shape of the pelvis. First of all, developmental causes. Small gynecoid pelvis, small android pelvis, small anthropoid pelvis. Later I show all type of pelvises. Small platypeloid pelvis or simple flat pelvis. Nagel Roberts pelvis is high assimilation pelvis. It's when the sacrum is composed of 6 vertebrae, or low assimilation pelvis when the sacrum is composed of 4 vertebrae, or maybe split pelvis. It's splitted symphysis pubis. Metabolic, it's rachitis or osteomalacia, triradiate pelvic brim. Traumatic, neoplastic, and diseases of the pelvic bones. Causes in the vertebral column: lumbar kyphosis, lumbar scoliosis, spondylolisthesis, when the fifth lumbar vertebra with the above vertebral column is pushed forward while the promontory is pushed backwards at the tip of the sacrum is pushed forwards, leading to outlet contraction. And another course is coccygeal deformation. Causes in the lower limbs: dislocation of one or both femurs, atrophy of one or both lower limbs, Nagel's pelvis, scoliotic pelvis, some diseases, or fractures or tumors affecting one side. Now we are discuss about shapes of pelvis. Today present 4 types of pelvis. It's gynecoid, it's first 50% of cases, anthropoid 25% of cases, android 20% of cases, and platypeloid it's 5% of cases. The character of the posterior segment determines the type of pelvis, and the character of the anterior segment determines their tendency. They are both determined because many pelvis are not pure but are mixed types. For example, a gynecoid pelvis with an android tendency means that the posterior pelvis is gynecoid and the anterior pelvis is android in shape. At this picture, you can see differences between 4 types of pelvises. It's A, it's anterior, B, it's posterior. You can see how change shape of the pelvis in different types of pelvises. Gynecoid or female type. The brim is a transverse ellipse, almost like a circle. Anthropoid or ape type. The brim is a vertical ellipse, gynecoid turned round 90%. The transverse diameter, widest part of brim, and the available transverse diameter, a midpoint of anterior-posterior diameter of brim, coincide in the gynecoid and anthropoid pelvis. The hind pelvis in the area behind the transverse diameter, and the forepelvis the area in front. These areas are roundly equal in both the gynecoid and anthropoid pelvis. The delivery of the fetal head through these types of pelvis has equal mechanical problems at all levels. If it is easy at brim, it should be easy in cavity and outlet. Next type, it's android or male type. Brim is roundly triangular, transverse diameter near sacrum. Available transverse diameter is shortened. The area of the hind pelvis is reduced and shallow. Area of the fore pelvis is reduced and narrowed at front. The delivery of a fetal head through this pelvis gives increasing problems the further it descends. It may be easy at upper part in plain inlet, but impossible lower. And last type, it's platypeloid type. Brim is kidney shaped. Transverse and available transverse diameter coincide. The hind pelvis is shallow and the area reduced. Fore pelvis is shallow and the area reduced. The delivery of a fetal head through this pelvis meets problems at the brim, but thereafter the difficult decrease with descent. If it's descent through first plane, usually low, absent any problems. If, for example, small size of the fetus and fetal head descend through the first plane. And you can see differences at this picture. I combine all types together, and now again you can see differences between all four types of pelvis. I repeat again that the best type is gynecoid type. It's oval shape of the first plane, and 50% of patients has this type of pelvis. Continue. What differences between female and male pelvises? At this picture you see the general structure. If female pelvis it's light and thin, if male it's heavy and thick. False pelvis, female pelvis it's shallow, male pelvis deep. Pelvic inlet larger and more oval in case female pelvis, and smaller and heart-shaped if male pelvis. Acetabulum small and faces anteriorly in case female pelvis, in case male large and faces laterally. Pubic arch, it's very important moment. If female pelvis is greater than 90-degree angle, and if male pelvis it's less than 90-degree angle. Later I show why it's important moment. You see that pubic arch more wider in case female pelvis. Anatomically contracted pelvis classified by a type and distortion of pelvic architecture and degree of contraction. First type is just a minor pelvis or generally contracted pelvis. In case just a minor pelvis is characterized by the general reduction of all diameters and anterior, posterior and transverse and both oblique diameters. They all are equally shortened by 1, 2 or sometimes more centimeters. Pubic arch is narrow, has the same shape as a normal pelvis, but all diameters are shortened. Pelvis occurs in women with short stature and thin women, and in women with signs of infantilism. Infantilism it's a condition when decreased level of sexual hormones and more slow development happen. Also occurs in women with massive skeletal bones and developed muscles. The pelvis has masculine features such as narrow sacrum, narrow pubic outlet. The pelvic architecture is characterized by the narrow sacrum and narrow pubic arch. The pelvis is especially contracted at its outlet. If we have just a minor pelvis, what management at this situation? First of all, one of complication is prolongation of labor. Considerable fetal head flexion, thanks to which it is elongated in the occipital frontal diameter, and we have dolichocephaly shape of the fetal head. Posterior fontanel is situated into the axis of pelvis, normal denominator, such as normal labor in occipita anterior presentation. Considerable molding of the fetal head. Caput succedaneum is formed in the area of posterior fontanel. Below picture, you can repeat why it's happened. Why happened formation of caput succedaneum? With increasing narrowing of the pubic arch, the occiput cannot emerge directly beneath the symphysis pubis, but is forced increasingly farther down upon the ischial-pubic rami. The perineum becomes increasingly distended and thus exposed to greater danger of laceration. And at this situation, management of labor, vaginal delivery is possible. But later I show degrees of contracted pelvis, and I must say that vaginal delivery is possible if present first or second degrees of contracted pelvis. Next type of contracted pelvis is flat pelvis. At this situation, happen reduces anterior-posterior diameters with normal transverse and oblique diameters. Simple flat pelvis is defined as a shortening of anterior-posterior diameters at all levels of true pelvis. As a result of this, sacrum is inclined anteriorly to pubis. Flat tracheitic pelvis, its anterior-posterior diameter of the pelvic inlet only is reduced. And generally contracted flat pelvis, all diameters reduced, but the anterior-posterior diameters are shortened greater than the others, usually connected with rachitis in the childhood. Next, simple flat pelvis. The entire sacral platform is dislocated towards symphysis, and hence the anterior-posterior diameters of all pelvis planes are reduced. The bones of the pelvis of the skeleton are not disfigured. The body build of women with a simple flat pelvis usually is normal. Flat tracheitic pelvis. It is marked by distorted bones. the wings of the iliac bones are set wide apart, and the distance between the anterior superior iliac spines is increased so that the interspinal diameter is almost the same as the intercristal one. The sacrum is shortened, flattened, and turned. The sacral promontory is displaced anteriorly to an appreciable extent. Additional promontorium may be presented between first and second vertebrae of sacrum. The pelvic inlet plane has the shape of a bean. The diameters of the pelvic outlet plane are normal or increased. The pelvic angle is wide. The cavity in a flat tracheitic pelvis is normal or slightly increased, and the true conjugate is reduced. Course of labor in flat pelvis. First of all, of course, again, it's prolongation of labor, because necessary more long time for engagement, more long time for molding of the presenting part. Sagittal suture resting in the transverse diameter of the plane of inlet. Anterior fontanel is the leading point or denominator of the fetal head. Asynclitism should be present. At this picture, you can see two types of asynclitism. It's anterior asynclitism, because we can palpate more anterior parietal bone. And it's posterior asynclitism, because first of all, during vaginal examination, we can palpate posterior parietal bone, and sagittal suture deviate to the pubic symphysis. In case anterior asynclitism, sagittal suture deviate to the sacrum. Usually, labor possible in case anterior asynclitism, but in case posterior, natural labor impossible, and it indication for cesarean section. But management of labor in the case of posterior asynclitism, such as I said before, it's cesarean section, and vaginal delivery in a flat tracheitic pelvis possible, again, if it's first or second degrees of contraction and present normal engagement or anterior asynclitism. I show again what differences between two types of asynclitism. It's normal engagement. You see that sagittal suture in middle position. It's anterior asynclitism, because anteriorly anterior parietal bone and sagittal suture deviate to the sacrum, and it's posterior asynclitism. I repeat again, this type of engagement, it's indication to cesarean section. Now I show rare form of contracted pelvis. For example, it's autopelvis. It's developed as a result of inflammatory processes in the hip or the knee. The healthy leg carries the main weight of the body, and the acetabulum of the healthy hip becomes depressed, permitting the head of the femur to protrude inside the pelvis and to contract the pelvis. Of course, present many types of rare forms of contracted pelvis, but I show some of them. For example, prostrate pelvis or break pelvis is formed in undevelopment of both sacral wings. or spondylolisthetic pelvis is the rare form of abnormal pelvis. It is formed due to partial dislocation of the last lumbar vertebra in front of the first sacral vertebra. Look at this place. Spondylolisthesis. Another rare form is osteomyelitic pelvis. Is extremely rare phenomenon, promontory pushed downwards and forwards. Lateral pelvic walls pushed inwards, anterior wall pushed forwards to form a beak, brim assumes trifilate shape, and pubic angle narrowed. And of course, at this situation, and this form and all previous rare form, it's always indication for cesarean section. Another type of abnormal pelvis is scoliotic pelvis. Only the lumbar region causes deformity of the pelvis. The acetabulum is pushed inwards on the weight-bearing side. I haven't picture, sorry. Scoliorachitic pelvis, it's if there is any marked lateral spinal curvature, it produces such as a pelvis. Split pelvis, physiological separation of pubic bones during later months of pregnancy. Extreme cases gap may be as large as 10 centimeters with fibrous band covering it. Ectopy of bladder may occur. Assimilation pelvis, variation of number or type of sacral bones fusing to form a sacrum. Low assimilation sacrum has 4 bones, and high assimilation its sacrum consists of 6 bones. And obliquity of plane of brim is affected. Low type, low obliquity, so head enter brim easily. And high type increased obliquity, thus head enters with difficulty. At this picture you can see Nagel's pelvis arrested the development of one ala of the sacrum with narrow sacral bay, conjugate diameter little affected, oblique diameter unequal, transverse diameter much reduced, and the low picture it's Robert's pelvis. Both ala are ill-formed, rarest form of deformity. It's again for management. If pregnancy happen, we terminated this pregnancy by cesarean section. And now important information. Next important information, it's pelvic classification according to degree of contraction. And we are diagnosed degree of contraction according to conjugate. If you remember, true conjugate is distance between sacrum promontory to the upper inner part of pubic symphysis. Present 4 degrees. Its first degree, the true conjugate is 11 to 9 centimeters. At this situation, vaginal delivery is possible, but complication may arise. Now, you see that second degree when true conjugate is 9 to 7.5 centimeters. Same, vaginal delivery is possible, but of course doctor must be very attentive and in time diagnose complications if they happen. Third degree, its true conjugate is 7.5 to 6 centimeters. At this situation, spontaneous delivery of a mature fetus through the natural birth canal is impossible. I pay you attention in case mature fetus. if gestational age more than 37 weeks of pregnancy. Forceps delivery or traction by the pelvic end also fail. The fetus can only be extracted through the natural birth canal after a destructive or destroy operation of the fetus. A live fetus can be delivered by a cesarean section. And fourth degree, when true conjugate is 6 centimeter and less, spontaneous delivery is impossible. Destructive or destroy operations of the fetus also fail to deliver through the natural birth canal. The pelvis is so contracted that it cannot pass even small parts of the dissected fetus. A cesarean section is the only possible way to deliver. This degree of contractive pelvis is always known such as absolutely contracted pelvis. I repeat again, 4 degree in both cases, alive fetus or dead fetus, only cesarean section. In 3rd degree, alive fetus, cesarean section, dead fetus, destroy operation. Now we tell about diagnosis of contracted pelvis. First of all, main part of diagnosis is history or anamnesis, because we must know about different diseases or traumas of the pelvis. Maybe about some hormonal changes, hormonal diseases, about previous tuberculosis of bones and joints, bad obstetric history, prolonged labor ended by difficult forceps, cesarean section or stillbirth. We must know weight of the baby and evidence of maternal injuries such as complete perineal tear, vesicovaginal fistula, rectovaginal fistula, and other. What examination? Of course, first of all, it's general examination. It's gait, abnormal gait suggesting abnormalities in the pelvis, spines, or lower limbs. Stature, women with less than 150 centimeters height usually have contracted pelvis. Spines and lower limbs may have a diseases or lesion. Manifestation of rachitis as square head or some other signs of rachitis. Dystocia dystrophia syndrome. The woman is short, stocky, subfertile, has android pelvis and masculine hair distribution with history of delayed menarche. This woman is more exposed to occipital posterior position and dystocia. Next type of examination is abdominal examination, non-engagement of the presenting part. In the last 3-4 weeks in primigravida, absent normal engagement. Pointed abdomen in primigravida with a resilient abdominal wall. Pendulous abdomen in multiparous women, and malpresentation are more common because absent normal engagement. Such as you remember, malpresentations, it's brow or face or vertex presentation. For diagnosis, of course, we use external pelvimetry. External pelvimetry is a routine method, it's obligatory method for all patients, which helps to imagine the internal volume of the true pelvis. The measurement is done facing the patient's face. Doctor near right side of the patient. The patient is in dorsal position on the back. The required tool is pelvimeter. The main external sizes, such as you remember, are distances spinarum. It's distance between two anterior superior iliac spines. Normal number is 25-26 centimeters. Distance spinarum or intercristal diameter, it's same. It's distance between the most widely distant points on the outer border of the iliac crests. Normal number of this diameter is 28-29 centimeter. Its distance spinarum or interspinous diameter. Its distance cristarum. Next one, it's intertrochanteric diameter or distance between the trochanters on both sides. Normal numbers is 31-32 centimeters. Of course, all these parameters, all these numbers you must remember from the first half of your cycle on fourth course. And last obligatory diameter, it's external conjugate. It's distance between the fifth lumbar spine or lumbar vertebrae and upper part of pubic symphysis. And this distance must be 20-21 centimeters. But how we can know about length of true conjugate? For measurement of true conjugate, additional parameter it's Solovyov index, because true conjugate we can calculate if we subtract some centimeters from the external conjugate, we can know about true conjugate. But what is Solovyov's index? It is estimated by the circumference of radiocapital joint, and normally length is from 14 to 16 centimeters. It can indicate into bone's pelvic thickness and help to imagine the internal volume of a true pelvis. If normal numbers of Solovyov index for calculate length of true conjugate, we subtract 9 centimeters from conjugata externa. I show again, it's conjugata externa. Conjugata externa. But true or conjugata vera from promontorium to upper inner part of pubic symphysis. If normal size of Solovyov index, we subtract 9. If this index is less than 14, at this situation we know that bones are thin. At this situation we subtract 8 centimeters from conjugata externa. At this situation the bones are thinner, the internal volume bigger. If more thinner bones, more wider cavity of pelvis. If this index, Solovyov index, is more than 11 centimeters, we subtract 10 centimeters. At this situation, the bones are thicker, the internal volume less. If we think about contracted pelvis, we have additional sizes, such as, for example, lateral conjugate is a distance between the anterior superior iliac spine and posterior superior iliac spine of the same iliac bone. It has 14.5 or till 16 centimeters, and of course in both sides of the body there must be same. Another additional size is oblique conjugate, is a distance between the right anterior superior iliac spine to the left posterior superior iliac spine. It has 20 to 21 centimeters and again must be same in both sides. Additional method of diagnosis, it's measurement of Michaelis rhomboid. The shape of Michaelis rhomboid is very important for diagnosis of pelvic structure. Two sizes are distinguished in the rhomboid. It's longitudinal between its top and bottom corners, and transverse between lateral corners. I must say that upper part, it's joint of L5S1. Lower part, it's tip of sacrum, and lateral angles, it's spina iliaca superior posterior. And each of these sizes is 11 centimeters. Sometimes vertical diameter or longitudinal, it's 11 centimeters, such as conjugata vera. And transverse diameter, it's 10 to 11 centimeters. It must be normal, symmetrical rhomboid. If present some abnormalities of shape of this region, we can think about some types of contracted pelvis. You see that normal symmetrical rhomboid in case normal pelvis. Look, in case just a minor pelvis, when all sizes decrease on 1 or 2 centimeters, again it's usually symmetrical but less sizes of rhomboid. But in case flat tracheitic pelvis, decrease size of true conjugate and decrease vertical diameter, vertical size of Michaelis rhomboid. It's some type of oblique pelvis. You can see that all sides they are different. It's very easy for diagnosis, and if we diagnose abnormal shape of Michaelis rhomboid, we must continue our diagnostic, and because we must know about management, we must choose correct tactic for labor, for delivery. Next, pelvic capacity. Any contraction of the pelvic diameters that diminishes its capacity can create dystocia during labor. There are many big contractions of the pelvic inlet, the mid-pelvis, or the pelvic outlet, or a generally contracted pelvis may be caused by a combination of these. Pelvimetry. It is assessment of the pelvic diameters and capacity done at 39 weeks. It includes internal pelvimetry, is done through vaginal examination, the inlet palpation of the pelvic brim. The index and middle fingers are moved along the pelvic brim. Note whether it is round or angulated, causing the fingers to dip into V-shaped depression behind the symphysis. Next, diagonal conjugate. Try to palpate the sacral promontory to measure the diagonal conjugate. Normally it is 12.5 centimeter and cannot be reached. If it is felt, the pelvis is considered contracted, and the true conjugate can be calculated by subtracting 1.5 centimeter from the diagonal conjugate. This assessment is not done if the head is engaged, only if presenting part above the first plane. I repeat again, diagonal conjugate, its distance between promontorium and low part of pubic symphysis. And if we subtract 1.5 centimeter, we will know about length of true conjugate. I show again what is true conjugate, what is obstetrical conjugate, and what is diagonal conjugate. And at these pictures you can see how we measure diagonal conjugate. We do it during vaginal examination. We try to palpate by index. We try to palpate promontorium and fixate by another hand. We fixate point below the pubis, and after that we evacuate our hand, and after that measure this distance. Usually it's 12.5-13 centimeter. It's diagonal conjugate. If we will subtract 1.5 or 2 centimeters, we will know about true conjugate. The cavity. How we know about size of the cavity? Height, thickness, and inclination of the symphysis. We are palpated. We check shape and inclination of the sacrum, side walls, to determine whether it is straight, convergent, or divergent, starting from the pelvic brim down to the base of ischial spines in the direction of the base of the ischial tuberosity. Then relation between the index and middle finger of the base of ischial spines and the thumb of the other hand of the ischial tuberosity is detected. If the thumb is medial, the side wall is convergent, and if lateral, it is divergent. Ischial spines, whether it is blunt, difficult to identify at all, prominent, easily felt but not large, or very prominent, large and encroaching of the midplane. The ischial spines can be located by following the sacrospinous ligament to its lateral end. Interspinous diameter by using the two examining fingers. If both spines can be touched simultaneously, the interspinous diameter is 9.5 centimeter. Sacroischiatic notch, if the sacrospinous ligament is 2.5 fingers, the sacroischiatic notch is considered adequate. The outlet, subpubic angle, normally it admits 2 fingers. Such as you remember, it must be 90 degree, and we must if we can localize 2 fingers below pubic symphysis, it's normal situation. Transverse diameter of the pelvic outlet is the distance between the posterior portions of the ischial tuberosities. It has 11.5 centimeter. By tuberose diameter, normally it admits the closed fist of the hand. Mobility of the coccyx by pressing firmly on it while an external hand on it can determine its mobility. An anterior posterior diameter of the outlet from the tip of the sacrum to the inferior edge of the symphysis. It has 9.5 centimeters. But correctly said, from the tip of the coccyx to the inferior part of pubic symphysis. At this picture you can see how we can access mobility of sacrococcygeal joint, intertuberous diameter. It's transverse diameter, measure of transverse diameter of anatomical outlet, last plane. Assessment of pubic arch angle, assess interspinous diameter between two ischial spines, and spinal tuberose distance. Spinal tuberose distance, it must be 4.5 centimeters. And findings indicating adequate pelvis. I repeat it again. Maybe it's when the diagonal conjugate more than 11.5 centimeters, pelvic brim round, symphysis average thickness, sacrum average inclination, side wall straight, ischial spine blunt, interspinous diameter more than 10 centimeters, sacroischiatic notch 2.53 fingers, subpubic angle 2 finger, and bituberous diameter more than 8 centimeters or fist, size of the fist. Of course, for diagnosis, we can use some another types of pelvimetry. Sometimes we can use X-ray or CT or MRI diagnosis, but usually in practice, of course, we don't do it during pregnancy. Usually, if patient has some abnormalities of pelvis, or some diseases before, or some information about traumas or some other conditions, and if better use all these methods of diagnosis before pregnancy. Of course, not during pregnancy. But in practice, in literature, this information present. In case radiological pelvimetry, it is indicated mainly in borderline pelvic contraction. Lateral view, the patient stands with the X-ray tube or one side and the film cassette on the opposite side. It is the most important view as it shows the anterior posterior diameters of the pelvis, angle of inclination of the brim, width of sacroischiatic notch, curvature of the sacrum, and cephalopelvic relationship. Inlet view. The patient sits on the film cassette and leans backwards so that the plane of the pelvic brim becomes parallel to the film. And outlet view. The patient sits on the film cassette and leans forwards. A history of pelvic fracture warrants a careful review of previous radiographs and possible computed tomographic pelvimetry later in pregnancy. The examiner attempts to judge the anterior-posterior diameter of the inlet, the diagonal conjugate, the interspinous diameter of the mid-pelvis, and the intertuberous distances of the pelvic outlet. A narrow pelvic arch of less than 90 degrees can signify a narrow pelvis. An undergated fetal head can indicate either excessive fetal head size or reduced pelvic inlet capacity. CT scanning. Of course, we can use it, but I repeat again, better do it before pregnancy. Effects of the contracted pelvis during pregnancy. In carcerans, such as I said before, abnormal shape of abdomen. It may be a malpresentation. It's abnormal engagement. During labor, maybe cord prolapse. Again, because absent normal engagement. It's slow cervical dilatation. It may be prolonged obstructed labor. If it's prolonged obstructed labor, increase risk of some infections such as chorionic neonitis. And for maternal and fetal injuries, we must say about maternal and fetal injuries. Injury at female genital tract, it may be fetal distress, formation of caput succedaneum or cephalohematoma or some another fetal traumas. Normally, cervical dilatation is aided by hydrostatic action of the unwrapped membranes or after their rupture by direct application of the presenting part against the cervix. In contracted pelvis, however, because the head is arrested in the pelvic inlet, the entire force extended by the uterus acts directly on the portion of membranes that contact the dilation cervix. And according to this information, I want to explain why happened early spontaneous rupture of the membranes. Because again, I repeat again, absent normal engagement. But again, if absent normal engagement, if early rupture of membranes, more slowly dilation of cervix, and high risk of prolapses of loops of umbilical cord. After membrane rupture, absent pressure by the head against the cervix and lower uterine segment predisposes to less effective contractions. Thus, cervical response to labor provides a prognostic view of labor outcome in women with inlet contraction. A contracted inlet plays an important part in the production of abnormal presentations. In normal nulliparas, the presenting part at the tomb commonly descends into the pelvic cavity before the onset of labor. When the inlet is contracted considerably, however, descent usually does not take place until after labor onset, if at all. Cephalic presentation still predominate, but the head floats freely over the pelvic inlet or rests more laterally in one of the iliac fossa. Accordingly, very slight influences may cause of fetus to assume other presentations. In women with contracted pelvis, face and shoulder presentations are encountered 3 times more frequently, and the cord prolapses 4 to 6 times more often, such as I said before. What management in case contracted pelvis? Before I say that if first or second degrees possible natural labor, third degree if a live fetus, it's indication for cesarean section, and fourth degree it's absolute indication for cesarean section. But I divide on some groups. Preterm induction only for mild degree of contraction. Not favorite is in present day practice. In multigravida with prior history done 2-3 weeks prior to due date. Trial labor. Conducting spontaneous labor in moderate disproportion under supervision with facilities of the intervention available at hand. And I want to say that present indication for planned cesarean section in women with a contracted pelvis. You see again, contracted pelvis of the 3rd and 4th degrees. I repeat again. Next, it's contracted pelvis of the 1st and 2nd degrees in combination with a large fetus or big fetus. It's more than 4 kg pelvic presentation or breech presentation and pregnancy overgrowth, overterm pregnancy. Obstetric history, if in anamnesis stillbirth or infertility or some another problems. If present scar on the uterus, the presence of genital urinary and intestinal genital fistulas, or incorrect position of the fetus. It's not only malpresentation, abnormal engagement in case cephalic presentation. Yes, it's brow, vertex, and face. But if present oblique or transverse lie of the fetus. Now, very important part of our lecture, we will discuss about cephalopelvic disproportion. It's situation when baby's head too large to fit through the mother's pelvis. I repeat again, cephalopelvic disproportion is a pregnancy complication in which there is a size mismatch between the mother's pelvis and the fetus head. The head is proportionally too large, or the pelvis is too small to easily allow the baby to fit through the pelvic opening. This can make vaginal delivery dangerous or impossible. If an attempt vaginal delivery is unsuccessful, doctors should quickly move onto a cesarean section. I repeat later about it again. If they fail to do this, prolonged obstructed labor from cephalopelvic disproportion may result in birth injuries such as hypoxic ischemic encephalopathy and cerebral palsy. But not only this. Later I show that possible some another complications. Anatomy of cephalopelvic disproportion. The womb and the birth canal are surrounded by the bones of the pelvis. The opening in the pelvis that the baby passes through is only about 11 centimeters wide at its narrowest point. Common risk factors, it's fetal macrosomia, it's big fetus, it's narrow contracted pelvis, it's gestational diabetes, and post-term baby when abnormal molding of the presenting part, abnormal molding of the fetal head. Absolute its permanent maternal cause such as contracted pelvis and anterior sacrococcygeal tumor, and temporary fetal causes such as hydrocephalus and large baby and another. It depends what obstruction. Absolute if present mechanical obstruction. And relative cause, the relative cause includes brow presentation, face presentation, vertex presentation, accipita posterior position, some abnormal position of the fetus. What diagnosis? Diagnosis or signs of clinically contracted pelvis or cephalopelvic disproportion, it's same. Of functionally contracted pelvis. First of all, it's a resting of the head in the pelvic inlet. It's uterine contraction abnormality. It's positive Vasten sign or Zangenmeister sign. Signs of urinary bladder compression. Edema of the cervix and vaginal walls, production of fistulas, dangers of uterine rupture, over distension of lower uterine segment, and pushing occurs in location of fetal head in inlet. At these pictures you can see Vasten sign. The best type, it's you can see on this picture, it's negative Vasten sign. You can see that presenting part locate lower than pubic symphysis. In this situation, presenting part on same plane, it's full brim. We say that at this situation, Vasten sign full brim, and positive Vasten sign when presenting part higher than pubic symphysis. Of course, in to this situation, we have complication during labor. It's absolute cephalopelvic disproportion. Typically, the first stage of labor will be prolonged. In case functionally contracted pelvis, there is failure of descent of the head, apparent on both vaginal and abdominal examination. Molding will occur and is the process is in which the fetal skull bones override each other. The parietal bones override each other commonly, and both overlie the frontal bones. Happen molding. This occurs in normal labor, but in cases of cephalopelvic disproportion, the molding is irreducible. The bones will not separate. Caput formation, in which the subcutaneous tissue and skin of the vertex become edematous, is a feature of the duration of labor rather than cephalopelvic disproportion. Additional method for diagnostic, it's Muller-Monro Kerr method. How we will do it? 2 fingers of examining hand into the vagina with tips at level of ischial spines, thumb placed over symphysis. Muller's method. We palpate all symphysis. As suggested by Monro-Kerr, the head is grasped with the left hand and pushed down and back into the pelvis. Monro-Kerr's method of assessing for engagement. Result. The head can be pushed down up to the level of the ischial spines, and there is no overlapping of the parietal bone over the symphysis pubis. At this situation, no disproportion. The head can be pushed down a little but not up to the level of ischial spine, and there is slight overlapping of the parietal bone, slight or moderate disproportion. And the head cannot be pushed down, and instead the parietal bone overhangs the symphysis pubis, displacing the thumb. It's severe disproportion. What complication possible in case functionally or clinically contracted pelvis? Fetus does not engage but remains floating. Such as result, it may be trial labor, prolonged labor, a delayed second stage of labor because happen over distension of the uterine wall. Maybe preterm or premature rupture of membrane. I explained it before. Maybe uterine cord prolapsus, or if all these factors, such as result, can provoke fetal distress. I repeat again, if prolonged labor, increased risk of some infections during labor. And possible other complications is rupture of the uterus if we are not diagnosed correctly in time. That happen cephalopelvic disproportion, happen over distension of the low segment of the uterus, and such as result possible laceration or rupture of the uterus or hysterorhexis. Possible infringement of soft tissue with prolonged standing of the head in same plane of the pelvis, followed by the formation of genitourinary and intestinal genital fistulas. Another complication, of course, is injuries of the joints and nerves of the pelvis, or fetal injuries. It may be fractures of the skull bones or formation of cephalohematomas, fracture of the clavicular bones, upper extremities bones, and other. And more dangerous, the most dangerous complication, it may be death of the woman if, for example, happen rupture of uterus, or maybe death of the fetus if happen fetal distress or some dangerous trauma such as intracranial hemorrhages and other. And last slide, it's management. What management in case clinically or functionally contracted pelvis or cephalopelvic disproportion? I repeat again, it's same situation. If the size of the fetal head does not correspond to the pelvis of the mother, if diagnosed fetal distress, signs of the threat of rupture of the uterus, if developed threatened rupture of the uterus, these are indication for emergency cesarean section with a life, if fetus alive. In case of intracranial intranatal fetal death, we must stop labor activity, and we use fetal destroying operation. Thank you for your attention. Be healthy.